As the captain of the Titanic famously said, let's get underway. So here's a brief outline of where we're going to be going here today. To start off, we're going to do a very brief update from CareOregon Pharmacy on opioid benefits. Then we'll move through the rest of the program with our speakers here today. Here's our main learning objectives that we're hoping you'll come away with. Here's kind of a round table view of where we're going. So we're going to start off today with a pain benefits update and then take it from there. So to begin that, directly from CareOregon's pharmacy team, we have Dr. Cassandra Miller starting us off today. Cassandra received her PharmD and Master's in Health Informatics from the University of Findlay College of Pharmacy in beautiful Findlay, Ohio. She's currently training at CareOregon as a postgraduate managed care pharmacy resident. She has experience in population health medication, therapy management, formulary management, and pharmacy benefit design. Dr. Miller's research is focused on opioid tapering initiatives in a rural CCO, as well as barriers to safe opioid management. Please welcome Cassandra Miller.
Thank you.
There you are, my friend, right hand.
Awesome. Hi, everyone. So yeah, we'd be remiss if we brought you in here today and didn't talk to you about our benefits. And there's a lot happening across the state on cracking down on the use of opioids. So we wanted to kind of give you an update of where we're at CareOregon with that. So after today's presentation, you'll be able to explain the current trends in opioid utilization, describe the Oregon Health Authority opioid changes and kind of the why this is happening, outline the plan level changes here happening at CareOregon, and list non-opioid options, including non-pharmacological options that are covered by CareOregon's benefit. So in order to have an appreciation for this topic today, I think we need to have an understanding of kind of how we got to where we are. And a lot of you have heard this before, presented in many different ways, but we'll go ahead and breeze through this real quick to kind of get everyone on the same page. So starting in the early 90s is when we saw the push to start using opioids to treat pain, and prescribers were getting pressured to treat pain with opioids. And around the same time, we also had the JCO adopted the fifth vital sign of pain. So I don't know how many of you were practicing at that time. Do you remember the shift to starting to ask patients to rate their pain, and there were metrics assigned to it? So we saw that shift, and even chronic pain was then designated with an ICD-9 code. There was no diagnosis of chronic pain before that. So we saw a culture shift to everyone thinking that they deserved a life with no pain at all, and the only option to treat that pain was with medications and opioids. So over the years, over the past decades, we saw an exponential increase in the amount of opioids we were using. And that has then resulted in a lot of patients who are addicted to medication. They've been getting treated for long-term, and we've also seen an increase in overdose because of this. And the Agency for Healthcare Research and Quality recently reported a draft report showing that the effectiveness of risk of long-term opioid treatment for chronic pain found insufficient data on the long-term effectiveness. And when these medications were originally started and people were starting to get treated with them in the 90s, there was no data to show that these medications were effective for the long-term treatment of non-cancer related pain. And so we've also had the CDC come on and release guidelines this year, and the Academy of Neurology also independently reviewed the research and agrees that there is insufficient evidence for effectiveness. But what we have found evidence for is that there is a dose-dependent relation with serious harms and overdose with these chronic opioids. So this graph here shows us what that dose-dependent relationship looks like. And so we have here the dose in milligrams of MED, and what we see when we get beyond the 50 milligrams per day MED, we see our risk of overdose doubles. And this was this was 4 different studies that showed that. So this one showed double, but it can be even as high as 4 times the risk of overdose. And so to bring you up to speed, some of you might not know what MED is, but this is a common way to compare the different strengths of opioids. All the different opioids have different potency. So we use morphine as our baseline since it's one of the oldest drugs that we calculate what that morphine dose would be depending on the different strengths. So one of the most common opioids you see is hydrocodone. So that's a 1-to-1 ratio. Hydrocodone and morphine is 1-to-1. And then oxycodone and morphine is 1.5 is the ratio. So in your handouts, there's some nice CDC handouts. The one is calculating total daily dose of opioids. So it's a nice little handout showing you how to do that conversion. And then it also gives you a good estimate of what is 50 MEDs for some of those commonly prescribed medications, and even 90 MEDs. And then there's also a really nice calculator online. So if you have a patient who's on multiple different opioids, you can go on to this website and you can type in the total daily dose for each opioid, and it'll do a calculation of all of them. So now that we kind of understand the epidemic, we're going to take a look at what is the current state in Oregon. And this shows us the number of individuals with greater than 120 MEDs getting prescribed across the state. And we see it's a problem across the state, but especially on like our coast, we see an increased prescribing of those risky doses. And Tillamook and Clatsop County, where Columbia Pacific is, are in the top 5 right there on the coast. So it's a big issue all the way across the whole state. And we wanted to zoom in on the counties that CareOregon actually serves, that we're partnered with the CCOs in those areas. And on the left side is the county prescribing. So we have Clatsop and Tillamook, and then down here is Multnomah, Clackamas, and Washington, the metro area is in gray. And we have Jackson in red, and then Yamhill is in green. And so after all of this depressing topic of this big epidemic, we actually have encouraging results to show. Over the past year, this is from 2015 quarter 2 all the way through 2016 quarter 3, and we've seen a significant reduction in the number of patients who are on these risky high doses. Especially in Jackson County, they're doing great work down in Southern Oregon to reduce that risky prescribing, and it's been I think a 30% reduction. So it's not all bad news. Our partners are doing great work out in the community. You all are doing great work. So kind of explaining why the changes are happening across the state. We're cracking down on opioid prescribing because of the lack of evidence. And the state is saying we're not covering opioids anymore for the chronic back pain. And to help guide clinicians, they've released guidelines. Guideline Note 60 specifically addresses criteria for opioid use in back pain. And they're saying that the only treatment we should only be covering acute treatment, and we should be using the shortest duration and at the lowest dose possible after patients have failed non-opioid therapies first. But the question is, what about these patients who have been on these long-term doses? Are we just supposed to stop covering the opioids? There's a lot of downstream effects that could happen, like withdrawal. And so the state realizes that, so they've also released guidelines for tapering timelines. And the goal is that by January 2018, opioid therapy would be done, and they wouldn't be covering any more opioid therapy for these patients. So CareOregon, this explains our strategy. We want to expand the non-pharmacological services that are evidence-based without this worry of overdose. So we cover, I'll list the items that we cover later, but that includes acupuncture, chiropractic care, and physical therapy. And we also want to reduce the unsafe opioid utilization. So we'll do that with some formulary restrictions that I'll explain to you and our timeline for that. Continued medication-assisted treatment, and also increased naloxone access. We recently lifted the prior authorization on nasal Narcan for patients. So in the meantime, while we're tapering off patients, we want to make sure that they can get the nasal Narcan to prevent their risk of overdose. So these are the 2 big opioid benefit changes that are happening. First of all, there'll be a prior authorization on all strengths of morphine extended release. So previously we only had a prior authorization on a few of the higher strengths, but now it'll be all of the strengths. And also there'll be a quantity limit on all short-acting opioids to 120 milligrams morphine equivalents daily. So our timeline for this is, it'll be a 3-phase timeline, and starting January 1st, all new starts only will have the prior authorization for the morphine, and also the 120 MED restriction will go into place. So this is only going to prevent people from getting on these opioids. But what about the people who have been on it chronically? Just like the state realizes that we need to have a taper timeline, we'll give those patients until Q2 for the acute users, and then also by the end of 2017 for the chronic users to get off those high doses of 120 MEDs. So here's a list of the non-pharmacological treatments that we cover. Acupuncture is covered without a prior authorization. Chiropractic care and physical therapy is covered, but it does require a prior authorization. And then the guidelines say that patients can get up to 30 sessions per year of any combination of these services with medical necessity. And here's a list of our formulary non-opioid alternatives. And we have acetaminophen. We have over, I think, 10 NSAIDs that are covered. Carbamazepine, gabapentin. Lyrica requires a prior authorization, and the only indications are listed here that it's covered for. And they have to fail gabapentin first in order to get Lyrica. Topical capsaicin and topical lidocaine gel is covered. The patches, lidoderm patches, are non-formulary. And then also SNRIs and TCAs are covered through the state under DMAP. And there's also a nice handout from the CDC that's in your packets, and it shows the level of evidence and some of the agents that I talked about here, and some comments about them and harms listed with them. And then on the back it shows some of the common conditions that we use them for, including low back pain, migraine, osteoarthritis, and neuropathic pain. So some of the future considerations are to phase out all chronic morphine ER users. So like I said, these formulary changes are only affecting and preventing people from getting on the new starts on these medications, but we haven't gone back and retrospectively taken off the people who have already been on them previously. So that's a hopeful thing in the future that we'll go ahead and do. And then also lower the quantity limit of MED threshold. So right now we set the bar at 120 MEDs. In the future, we'd like to lower that bar, or I guess it would be raise the bar, and lower that down to 50 MEDs over time, because we know that that is where the risk of overdose increases. And there's also a handout also included. It's frequently asked questions about the opioid benefit changes, so it would be good to bring back to your teams at your clinics and share with them some of the changes that are happening. It kind of goes through what the benefits are, and it gives examples of what those daily limit doses would be. So for oxycodone 5 milligrams, the equivalent of 120 MEDs is 16 tablets per day. And then it also shows why these changes are happening, and then what prescribers can do to help. So one of the main things that they can do to prevent the prior authorization when patients go to take their prescriptions to the pharmacy is write the duration of supply, like intended supply. When we have these ambiguous directions of take 1 to 2 tablets every 4 to 6 hours as needed, often the day's supply that is ran at the pharmacy is for, 50 tablets for 3 days. And really the doctors don't intend for that to be what the patient actually takes over the time of 3 days. So if they really make it a point to write up to 8 tablets per day, there'll be less disruption for their patients in getting them the medications they need. So that is all I had for you. Do you guys have any questions about the benefit changes happening? Go ahead.
In terms of the number of acupuncture, chiropractor, PT, total number of visits, is that for a single diagnosis, or if they have a different diagnosis, would that reset the clock?
So that's a really good question.
I can answer that.
Go ahead.
That's only for back pain.
Okay.
And what about knee pain? So any other condition, CareOregon specifically, I don't know about. I think acupuncture is.
So technically
non-pre-op.
acupuncture is non-pre-op. So if someone was getting acupuncture, that could be excluded from the total of 30 and for a different diagnosis.
Oh, yeah, with CareOregon, right, that's right. So if it's back pain, then actually it's up to 4, and then if they have indications of complexity and how CareOregon chooses to spell that out hasn't really been designated yet. But if they show indications of complexity, then they can get up to 30 of chiropractic acupuncture, or I guess it would be chiropractic and physical therapy. If it's another condition, then for rehab, for PT, CareOregon provides 4 for any diagnosis.
So each new diagnosis would give them an additional 4.
That's my understanding. That's my understanding.
Before prior authorization, and then you would, for anything beyond 4, you would need prior authorization.
Yeah, I'm not sure they give a lot more than that anyway, but yeah.
All right, thank you, Cassandra. Okay, gang. So I know we have a few people still coming in. Let's go ahead and move along, though, with our program here today. Throughout the rest of our content, we're going to try to make an effort to actually kind of work in and present an actual case study to go ahead and make this a little bit more impactful, a little bit more real world for you guys here today. So we're going to, before we do our primary 2 segments, we're going to introduce this case study here to you. And to do that today is one of our main presenters, Lydia Bartholow. Lydia is an advanced practice psychiatric nurse practitioner with a doctorate in the overlay between trauma and addiction. She's a frequent lecturer across Oregon and the West Coast on trauma-informed addictions care and health justice. She's currently working for Central City Concern in their primary care clinic, but has just accepted the position of Associate Medical Director of Substance Use Disorder Services. Please welcome Lydia Bartholow.
Thank you for that lovely introduction. It sounds way more important than I actually am. I'm going to also have Nora help me with this case study introduction, because the idea here, haven't you already seen this? The idea here is that we want to sort of ground the information that we're going to present for you all in the lived experience of working with a client. So what is it actually like to be in the room working with a client? What is this actually like for clients? So I want to introduce you guys to Laney, who's going to sort of follow us today. So this is Laney. She's a faux patient. She's not a real patient. Indeed, this is actually Mahara Shu, who works for CareOregon. So she's on my team, and in this particular day, she's acting as Laney. So Laney is sort of an amalgamation of clients that are relatively common in the population that I work with over at Central City Concern in Old Town Clinic. So she has a history of TBI, and that's in the context of intimate partner violence, which is incredibly common. She has a diagnosis of PTSD, she has major depressive disorder, and then she also has this overlay of persistent back pain. Currently, she's taking both opiates for her chronic persistent pain, and she's taking 2 types of benzodiazepines for her anxiety. That's how she came to our clinic. She has a history of being at the methadone maintenance clinic, which she reports as being for pain. And then her past psychiatric treatment history has primarily been with medication. So she has never done any trauma therapy. She's never done really any type of therapy. So she's been involved mostly in sort of specialty behavioral health in the community, which has mostly been sort of case management and then psychiatric medications, but no sort of targeted trauma therapy. She lives alone in a SRO-like apartment. Her community is sort of in that building. She doesn't have a lot of connections to family. And then I'll leave Nora to talk a little bit more about her pain. But what we can tell you here is that she uses a walker that a friend loaned her, which is not always the easiest because her building is not the most convenient for having a walker. And then we'll go back here for a second. One of her biggest sort of strengths and her big love in life is her dog, Chloe. And then Nora, who will be introduced in a second, is going to talk a little bit about her pain.
And just to make things simpler, I'll introduce myself after we talk about this. So I want to go back for a moment and point out that she has pain with walking. She uses a walker that a friend loaned her, not that it was necessarily determined that she needed a walker to walk. Okay, so that's just one piece there to to put it in the puzzle. In her pain story, she has lower back pain, and we're going to talk about kind of what this means in looking at the neurophysiology of pain in a moment. It's been spreading in area across the lower back, bilateral lumbar spine, and up into the left upper back, into the thoracic spine. It's hard to tell where it is sometimes, and it's worse with cold weather. And it's worse with walking. She had some tests done that showed moderate degeneration on X-ray in the lumbar spine. And moderate degeneration, by the way, is something that lots of people have. No MRIs, but Laney's requesting that because her pain's been getting worse. And she has concerns that something terrible is happening, and that something is about, that things will be about to get worse. When she experiences pain, that something bad is going to happen to her. Okay? The idea that pain and harm go together. And she has no history of having gone through physical therapy, just like no history of trauma treatment. And she has difficulty with transportation, and insurance had been a barrier in the past with physical therapy not having been covered. Only recently has physical therapy been covered with CareOregon patients, and a lot of people were simply uninsured. And uses the emergency department about twice, every 2 months. So pretty frequent user.